You are very prepared, Catherine.
Hi, Catherine. You can hear me but not see me.
Yeah, I can hear you both.
We're just gonna set up on the big screen, so I'll be with you in a minute. Okay.
Oh, fantastic.
Have you shared the sound?
I have no idea.
No, 'cause she's got no video,
Oh,
so she's just talking through.
No,
It's
she's
Catherine
doing a
gonna talk.
presentation. as
Yeah,
well.
but and you're doing it here.
Yes.
It's a bigger thing, remember, because you're gonna have to hold that. I'll turn you down a bit.
Thank you.
it's for us to go there after.
Catherine, can you hear everything okay?
Yeah, I can hear you fine, yeah.
We can't hear Catherine.
Oh,
Yeah.
Um,
So what do I need to?
that's what I'm saying. Have you shared? Because you're.
I just joined the meeting. I joined the breakout room.
We can't hear her very well. There's Jackie. Jackie, they can't hear Catherine very well.
can you hear me at all, or is it just not, you can't hear me very well?
No, I think I'm turned that down.
Yeah, there'll be a mic down the end.
Hang on a second, Catherine. We're just trying to figure out why we can't hear you.
Okay.
Can you say something for us, Catherine?
Hi. Can you hear me now?
Yeah, we can hear you now.
Oh,
You need to
brilliant.
get the other people in the chat to mute their mics.
They also. I think they've heard you, to be fair. It's just Catherine that's got a microphone, I think.
Yeah, I don't know what the noise is. It's not listening.
I think she's. So I think it's yeah.
Just let me know when you want me to
Oh.
start.
Yeah, no, don't worry. Can everybody online hear me okay at the moment? Yeah. Okay. Thank you for joining us today then, guys. We have got Professor Catherine Berry and Helen Wilson, who's the trial manager for TULIPS. So I will hand over without further ado to Catherine. This will disappear. There we go. Over to you then, Catherine.
Thank you, Melissa. So I'm going to cover the first half of the presentation, then Helen's going to talk to you about the trial, which has been taking place within your trust, and then I'm going to finish off on the end. So hopefully this will work, doing it with half in person and half online. So TULIPS stands for Talk, Understand and Listen for Inpatient Settings, and it's an NIHR funded programme grant aimed at improving access to psychological therapy in acute mental health wards. It's a 5-year programme grant made up of different work packages, and I'll talk to you about what those work packages involve in a minute. So in terms of the background, more than 1.5 million people in England have got severe mental health problems. And by severe mental health problems, we talk about things like schizophrenia, bipolar disorder, personality disorder, or severe mental health problems. Those problems often start early in life and have a significant impact on people's well-being, and also the well-being of their loved ones and society as a whole. Particularly when we think about a society as a whole in terms of the economic impact, The last estimate that's published suggested that the cost of care for people with severe mental health problems was around £12 billion a year, and that makes up more than half of the mental health and social care budget. A lot of that cost actually goes on providing inpatient care for people. So when people become acutely unwell, they need to be, or they're often admitted to an inpatient unit, and that's extremely costly because the level of care that's required. Despite the high costs, though, a number of independent inquiries have highlighted the poor quality of care in these settings, and in particular the non-therapeutic nature of inpatient care. Prior to getting this grant, which was actually awarded in 2017, there were two kind of key inquiries, one by Mind, the mental health charity, and one by the Schizophrenia Commission. And both of those highlighted in particular the anti-therapeutic nature of inpatient mental health care, and that something needed to be done about it. Just talking about just in terms of the quotes that people that appeared in these kind of inquiries that involved kind of surveys of people with experiences of inpatient care. People were talking about how that when they were experiencing acute levels of distress, they needed to kind of take a step away from the home environments and spend time in a place that felt safe and containing. They wanted opportunities to talk to people and to really value that one-to-one interaction time with nursing staff. I just put a couple of those quotes there so you can read about what people were saying in the surveys that they might have needed from inpatient care. It's just a sense of kind of taking time out from potentially chaotic or distressing lifestyles. But in terms of the reality, people experience something quite different in inpatient care. There wasn't that opportunity for one-to-one conversations or input from nursing staff. Sorry, I didn't anticipate that. Anyway, start. So in terms of people's quotes, they were saying that it was very not very therapeutic. There wasn't the opportunity for one-to-one input from nursing staff, and the staff focus was on preventing crises as opposed to kind of a more preventative approach that values kind of relationships and prevents crises and difficult behaviours from happening in the first place. So I'll just leave those quotes there for people to read. So the outcome of those surveys was to suggest that a radical overhaul of acute inpatient care is needed, and surveys highlighted that actually relative to the rest of the health service, inpatient mental health care was particularly poor. So the key CQC reports were echoing the reports of the independent inquiries, highlighting that actually we do need better provisions in these services. And in particular, the reports are saying better access to psychological interventions. Because we know that psychological therapies or talking treatments help people with severe mental health problems, and we know that there's lack of access to psychological therapies across the mental health service, and particularly for severe mental illness, but access within inpatient settings is particularly poor. And that's been shown by kind of CQC reports, but also through more independent audits that have been carried out through local NHS trusts. And of course, if people aren't getting the care that they need in the form of psychological treatments, that can either prolong admissions, or if people are discharged, it can mean that the needs haven't fully been met, so they end up back in hospital again quite quickly. So that led for the Mental Health Task Force in 2016, just before this grant was funded, to advocate that actually we need what's called referral to treatment access, which means that people need to be able to access psychological therapy on an acute ward. And that needs to be evidence-based interventions, it needs to be timely interventions, so when they need it, basically. But that creates a problem because we know that psychological treatments are helpful for people with severe mental health problems. But what we don't know from good quality studies is how to deliver those in an inpatient environment. The kind of traditional 16 sessions of therapy that we offer in the community isn't necessarily suitable for an inpatient setting where people are experiencing high levels of distress, and where people might not be admitted for a very long period of time, and they might have a very short stay of a few days or a week. So we need to look at how we can offer treatments differently. And the trials that did exist, or the studies that did exist evaluating psychological treatments in inpatient settings, tended to be uncontrolled studies, or tended to focus on very discrete groups of patients as opposed to the whole variety of people that might be admitted to an inpatient setting. So that was the essential impetus for the grant. As so it's a programme grant, so it's made up of different components. We spent the first 18 months doing lots of qualitative work and literature searching and piloting work to kind of develop a psychological model or a way of working for specifically for acute inpatient wards, and I'll talk to you about those findings in a moment. And we're now at the point of nearly finishing a randomised control trial, where we essentially tested that intervention by randomising wards to either get the intervention or treatment as usual. And alongside that, we're around a third work package looking at qualitative work and observational work to see how the intervention was implemented in practice. And Helen will talk about those last two elements towards the end of the talk. So in terms of the first work package, or the first stage of the study, I say it took about 18 months, this whole kind of work package, and we undertook 4 different components. So we carried out a literature review, looking at what other studies and researchers had said about trying to implement psychological approaches on acute wards. We also carried out interviews with service users, professionals and carers about their experiences of mental health wards, and specifically what they had experienced or wanted in terms of psychological therapy. We then piloted a psychological service or intervention on 2 wards and looked at outcomes. And then we took all those findings and took them to a group of experts, and that was experts by experience, so service users, carers, and clinical experts and academics to kind of devise the final model, and that's the model that we tested in the trial. So in terms of the first work package, which comprised the qualitative interviews and the literature search, we found a number of different themes. The results of these studies are described in some publications, which I've put on the slides, and I believe the slides will be available to you, and so you can read through the papers at your leisure, but I'll just briefly summarise the findings for you on the slides. So in terms of the barriers and facilitators to implementing psychological interventions on acute wards, we divided them into a number of different factors. So there were those to do with the ward environment, those to do with integration of care, models of care, patient factors and staff factors, and I'll talk to you about what specific findings were in those areas, broken down in terms of barriers and facilitators to delivery. So in terms of barriers, one of the key things that people talked to us about was models of care. So people very much saw an acute ward as being somewhere where people come in, get remedicated, and risk could be contained, and then they'd be discharged again very quickly. And that didn't leave a lot of room for psychological interventions, because where people are at the point where it was felt by staff that they could engage in some longer term work, they're ready for discharge. People also talked about to us in terms of models of care that actually some patients did access psychological therapy on acute wards, but those are the patients that were believed to have personality disorders, and people that received the label of schizophrenia or another type of psychosis. The belief was that actually you didn't need psychological approaches for this group of people. They were the group of people that responded well to medication or a short course of medication, and then they could be discharged without the need for psychological approaches. So people tell us actually to counteract that kind of culture and those models of care, we need kind of a strong leadership within the inpatient environment, which really values psychological models and ways of understanding problems regardless of diagnosis. Psychologists themselves need to be really visible on the wards in terms of advocating the psychological model, and you need to get buy-in from senior nursing staff and senior psychiatrists. So you need that seniority within the team that really values this way of working. And I've just put just a couple of quotes up there to kind of to capture kind of what people were saying in relation to the barrier around models of care and the potential solution. Okay. In terms of integrated care, as a key barrier was psychologists not being seen as part of the core members of the multidisciplinary team. So where there were psychologists attached to a ward, they're very much people that tended to just come into a ward and see patients and then kind of go away again. They weren't seen as kind of a core member of the team, which led them to being a bit separate and their kind of input not then integrated. And there was also, in terms of integrated care, lack of continuity between the care within the ward and the community. So people were saying to us, there's no point in starting psychological interventions on the acute ward because they're going to be discharged, and there's nothing for them in the community, and so there's no point. And in terms of counteracting that, people were saying, well, actually, psychologists, rather like the last theme, in order to be part of the team, they need to be ward-based. They need to be there, you know, every day, kind of being present and really being part of that team, and not just the professionals that kind of parachute in. It's also about valuing short-term work as well. So it's about seeing that actually, you know, even if people don't necessarily have the opportunity to have care continued in the community, there's actual real value in providing some short-term interventions while someone is an inpatient. And very much that perspective was something that was given to us by service users, as opposed to the staff, which are more cautious about wanting to offer interventions. People also talked to us about the importance of staff and psychologists having really good links with the community teams to allow that continuity of care. So even if there wasn't the opportunity to have the same psychological intervention in the community, the implications of any work that had been carried out could be transferred to the community settings. And so I've just put some few quotes up there as well that people can have a read if they wanted to. Last quote from staff member 2 is actually a psychologist talking about making the effort to get out in the ward despite it being quite an alien place to be. In terms of other barriers on a quite simplistic level, people were saying that often wards weren't designed to have therapeutic spaces. So wards were by virtue of what they were very busy, chaotic places, but there wasn't often a lack of privacy and lack of space to carry out therapy. So wards needed something quite simple. They needed a therapeutic room that was actually on the ward as opposed to one that was off the ward, because often patients don't necessarily have the leave to go off the ward. So just to thinking about how to create that really environment, and also using things like protected therapy time or quiet time on the wards when therapy could be offered to people when it was kind of less busy and didn't coincide with other things like medication rounds and ward rounds. And so I just put some of the quotes there, which are quite practical things, but quite simple and they need to be a fundamental, really, need to be in place. Okay. In terms of patient barriers, both staff and patients were concerned about patients' mental state and their capacity to engage in therapy. Patients talked to us about how they'd had prior negative experiences of therapy, often in the community, and they were reluctant to kind of try therapy again. They were concerned about the implications of talking, I guess particularly around confidentiality and what might that mean for the stay being prolonged. People also lack knowledge about what psychological interventions could provide. So in terms of solutions, patients talked to us about how having that psychology presence on the ward as well was really key in terms of helping them build motivation to attend therapy and learn more about therapy. And people also talked to us about the importance of having psychological input just to help them feel emotionally contained as opposed to doing something necessarily more active than that. They value just the opportunity to sit down and talk to a person or a psychologist about how they were feeling as opposed to anything necessarily more active in terms of working around symptoms or other experiences. And I just put a couple of quotes up there. In terms of the final barrier, the staff factors, staff talked to us about having lack of confidence in skills in terms of applying any psychological work. So there were things that staff might have been able to implement in terms of basic kind of psychosocial interventions, but they lacked the skill and confidence in doing that, even though it might have been covered in previous training. They also felt burnt out and overworked. And there's a culture of kind of carrying on despite those feelings and not acknowledging levels of distress. So people talked to us about how it's really important that if nursing staff were going to deliver psychological interventions, or it was important they were trained and supervised in them, and that the psychologist's role in the ward was about building relationships with staff in order to facilitate staff to talk about their emotional needs, and also give them the confidence and to know that someone is there to help them, to support them in their work. And just put a few quotes there about the barriers and the solution that we gleaned from our interviews. So in terms of the models of care, after having merged all the results of the earlier findings and kind of put them together in the consensus conference, we came up with a model of care, and the model of care is very systemic. So we felt it was really key that the psychologist is part of the whole system. They're ward-based, they're integrated with the nursing team, they're not a separate member of staff that comes into the ward. We felt that psychological models needed to permeate throughout the ward environment. So it's important that people receive a psychological formulation. So the focus is not on receiving a diagnosis, but a psychologically informed understanding of the development of their problems and their current distress. It's important that nursing staff as well are empowered to kind of deliver psychological approaches in very kind of structured, kind of guided self-help ways. And the idea would be that psychologists will carry a relatively small caseload, focused on kind of the reasons for people's admissions, assessment work, formulation work, but that would be a relatively small part of the job. The focus would be very much working with the MDT, so attending MDT meetings, handovers, staff support sessions, in order to infiltrate a psychological perspective into those meetings. Okay, so I'll hand over to Helen, who's now going to talk about a randomised control trial that we're currently nearing completion, and this is described in the protocol paper published in BMC Psychiatry.
Thank you, Catherine. I'll just hand you over to Helen now.
Hi everyone. Thanks, Catherine. Can everyone hear me? No, it's not on, is it?
I'll turn it off and then disappear from the mic desk. So.
If I speak loudly enough, can you hear me? Yeah, it's okay. Thank you, Catherine. So I'm going to talk about work package 2. So Catherine's touched upon work package 1. So work package 2, we gained ethical approval in July 2019, and we opened the research in October 2019. The design itself, so it's a single blind cluster randomised control trial, and embedded within that is a mixed method process evaluation. So single blind means the researchers are blind to treatment allocation, and cluster means we randomise the ward rather than the individual participant taking part. You can see from the numbers there, we've got a rather large sample size. So we're looking to recruit 384 patients, 510 staff, and 306 patients recruited at 6 months for voice. So this is, again, another study kind of embedded within the main RCT, and I'll touch upon that a bit later on in the slides. So planned number of sites, so we're aiming to recruit 34 wards, and the good news is, everyone, we've done it. We've met our quota, so that's fantastic, given the challenges we've all had in the NHS, especially around research as well. Recruitment period, it was open from November 2019 until December 2022. However, due to the pause in the study, we have put in for a costed extension, and we're hoping to, oh, that's a bit odd, isn't it? And we're hoping to complete the research in December 2023, and a couple of months for Catherine and I to complete the report. It will be mainly Catherine, as you can imagine. We have several data collection time points, as you can see here, baseline, 6 months and 9 months. We do actually collect some data at 3 months, which I'll touch upon shortly. So the treatment phase, we train the psychologist for a month, and then the intervention delivery lasts for 6 months on the ward. Trial period 38 months, and we recruit one ward per month, but obviously there's been a pause with that. Next slide, please, Catherine.
Sorry, I'm just trying to move on the slides. It's not working for some reason. Hang on. It's still got a bit stuck, that's it.
That's okay, I can see it now. Okay, so I've touched upon the first 2 points here, but just to tell you a little bit what the intervention entails. So each trust, the wards may be randomised to treatment as usual or receiving the treatment. Here we've recruited 3 wards within Lincolnshire at LPFT, which has been fabulous. We've worked with some colleagues in the audience, Melissa, Tracy and Noel, who's also the PI. Is there anybody else I've missed out? No, there are some other people in other breakout rooms. So if the ward receives treatment, they will receive a psychologist for 2.5 days a week, band 8 psychologist, and they will deliver the intervention for 6 months. And Catherine touched on the about the intervention, so it's 3 different levels. So they can provide formulation, staff training, and also one-to-one
patient, not interviews, therapy sessions. Next slide, please. Thanks, Catherine. So just to kind of give you a flavour of what the primary objectives are. So the primary objectives are reduction in occurrence of ward level serious incidents. So these are mostly collected by DATEX reports within NHS trusts, and also to improve patient wellbeing. So how do we collect this information, or how, how are we collecting this information? So the primary endpoints are we're assess risky behaviours using a number of reported serious incidents in the ward at ward level, like I've already said, that's collected by DATEX, and we also assess patient wellbeing using the Warwick Edinburgh Mental Wellbeing Scale, and to save on that mouthful, it's called WEMWEBS for short. We also collect additional data, and I'm sure Melissa will agree with me on this. We collect a lot of data in TULIPS. We do manage this mostly as a central study team, and we also have the REDCap database, and that's hosted by the Manchester Clinical Trials Unit. So we collect all the data at ward level, and that's at baseline, 3 months, 6 months, and 9 months. So that might be things such as, for example, bed occupancy, nurse and agency staff, sickness, whether patients are on a mental on a section within a ward. Measures we collect a self-report, and some of them are interview based, and we also collect health economic data, and we are also doing fidelity data as well, so ensuring fidelity to the model. Again, this slide is just reiterating what I've already mentioned, but we collect serious incidents, average length of patient stay, staff sickness, and you can read some of the others there, but I just want to point out we do also collect patient satisfaction with the ward environment. That's the voice component of the study. So we collect additional participants at 6 months. So our targets per ward are 11 patient participants, 15 staff participants, and then we recruit an additional 9 patient participants at 6 months. We also collect information, data rather, for staff satisfaction with the ward environment. Next slide, please, Catherine. So work package 3. So this is the other strand that Catherine mentioned. This is the qualitative arm of TULIPS, and we actually have a designated researcher who kind of runs this for us, obviously overseen by Catherine and other co-Is, Professor Dawn Edge and Paul Wilson, based at the University of Manchester. So this is a mixed methods process evaluation used to derive an implementation and training strategy for rolling out the intervention, and therefore increasing access to psychological therapies across the NHS. So what are the aims? There's 3 main aims for work package 3. We want to look at identify the structures, resources and processes through which delivery of the intervention is achieved, explore how the intervention activities trigger change, and determine contextual factors strengthen or impede the delivery and the function of the intervention. So there's 3 parts to this work package. So it's the fidelity assessment, it's a semi-structured interview, so that's going out and speaking with patients and staff participants, looking to recruit between 30 and 4 patient and staff participants. And we also have an observational study as part of work package 3. So this is where our researcher will go onto the wards themselves and kind of embed themselves in the ward, collect data, take journals, notes, and write these up. So it's a really kind of a thorough assessment of things. Next slide, please. So where are we up to so far in work package 2? So like I've already said, we've recruited 34 wards across the UK. Lincolnshire has 3, for example. We've got Derbyshire with 4. We've got Greater Manchester Mental Health with 11. So it just gives you a flavour of the spread. Uptake at baseline. So we've got 94% for staff and 85% for patients. And as you can see there from the, we'll give you the actual numbers. So for staff, it's 465, and for patients, 341 at baseline. We are waiting to open our 3 final wards in Derby, which is really exciting, given some of the challenges we've had, and recruitment can be difficult at the best of times. We've got some great retention rates there, so I'll just let you look at those numbers, but they're all for staff 80 plus and 75 for patients. In terms of the voice part of the study, where are we up to? So we haven't been able to recruit for the voice part of the study on several wards. So far we've recruited 153 out of 306, which is still fairly impressive. Next slide, please. Sorry, this slide is a bit small, but we just wanted to give you a bit of a snapshot of patient demographic at baseline. So if you just look at some of the figures, we've got 37 is the average age. There's some other figures broken down there, but primary diagnosis, as Catherine mentioned before, schizophrenia or schizoaffective, or psychosis. Next slide. Progress so far in terms of work package 3. Again, this is just to give you a snapshot of patient demographics. So we recruited 13 female and 6 male, and we're hoping to increase those numbers. So we've commenced observational work and qualitative on 6 case study wards, recruited 30 staff members and 19 service users. Next slide. So the impact of the pandemic on the study, and I'm sure this is relatable to, you know, lots of people in the audience here. We halted the project for 4 months from March 2020 and reopened again in August 2020. When I say reopened to in-person recruitment. We worked with our local clinical research networks to support in this period. For obvious reasons, some researchers couldn't go on the wards if they were shielding, or, you know, for all the circumstances. But to enable us to complete follow-ups and to be successful as we are now in terms of we recruited the wards, we submitted several amendments to allow us to complete follow-ups over the telephone, over Teams, email, letter. So it's been really helpful to do that, and actually it's allowed us to have a bit more of a flexible approach going forward now post-COVID. Other things that affected the study or are still ongoing are staffing levels. We've got staff turnover is high, sickness, other things. We have to deal with regular COVID outbreaks on wards, which impacts on follow-ups. It's been trickier to recruit psychologists post-COVID due to hybrid working now and other circumstances. It's not that attractive sometimes to work in an inpatient setting. That said, we have been successful in recruiting psychologists. And on the flip side to that, we have had more interest in the study post-COVID, because it's all hands on deck. If you are randomised to the intervention, you get an extra pair of hands. They can come on the ward and support. They're an integral part of the team. And I've also mentioned that we've put in a costed extension. Next slide, please. This is just some more guidance that was developed by your colleagues in GMMH to how to, guidance for psychology, we can read it there. And if you want the references, by the way, at the end, please contact Catherine or myself. Next slide, please, Catherine. I think it's over to you again now.
Okay, so just some reflections in terms of intervention delivery. So we've managed to recruit and train 9 psychologists across the study. As Helen mentioned, it's been really difficult to get psychologists onto the wards. So we have had to work very closely with trusts in order to try and get people in post, looked at opportunities for secondments, sometimes paying people at higher bandings, and kind of really had to be really quite resourceful with it. But we have managed to successfully recruit enough psychologists now, so that's really meant we can plough through and finish with the study. So that final psychologist then starts in October in Derby. In terms of the staff training in the wards, we were able to successfully train staff on all of the 16 wards that have been randomised to the intervention arm of the trial so far. What we have struggled with, though, is sometimes getting staff to attend the training and taking staff off the ward when wards are already understaffed. So the success has really varied, and we've really felt, as I mentioned on the next slide, that one of the key factors is not so much staffing levels, because that is an issue across the NHS. It's more to do with the degree of commitment we've got from managers to the project and to training in psychological models and supporting psychological models. When we have delivered the training, though, we've had positive, both quantitative in terms of feedback sheets, and qualitative positive feedback in terms of the quality of interviews that our researchers done with staff about the training. People have really valued the opportunity to have some additional training in psychological models and ways of working. We've implemented formulation and therapy sessions on the wards, which we've been able to audio record, and the idea is then we subject those to analysis to look at what's been covered and what in terms of quality of therapeutic relationships and quality of kind of formulation in the team formulation sessions. We've also got a therapist diary where our therapists have religiously recorded what they've been doing during the intervention period, so we can see how that maps onto our initial plans in terms of how what their role should look like. But we have found, so anecdotally, that the focus of the therapist time has varied across sites and wards depending on where the ward is up to in terms of their willingness to get on board with psychological ways of working.
Sorry, Catherine, we're just going to have to cut you short there. We've got the other team ready to come up and
Sure, yeah.
do their bit. So thank you for that. That was really informative. If anybody's got any questions, Helen is here live, or I'm sure Catherine would be happy to answer anything via email as well. So I will, if you've got anything that